Hello and welcome to Pain in the Podcast, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons, and I'm joined by the wonderful Dr. Joshua Craw and Don Woude, and today we're going to be talking about rheumatoid arthritis. Welcome in.
Hello and welcome to this week's episode of Pain in the Podcast. This is your bi-weekly dose of a bit of pain relief. Bi-weekly being every other week, not twice a week. We're not quite there yet. Maybe if you have more engagement, we can do that, but not quite now. This week, we're continuing our series on different conditions. We've covered one inflammatory arthritis, Anki-Spond, and now we're going to be covering rheumatoid arthritis.
Yeah.
So, yes, indeed. So that's... inflammatory arthritis is any arthritis that's typically caused by the immune system as opposed to wear and tear like osteoarthritis. And, well, this week I'm joined by the wonderful Dr. Joseph Parsons and the magnificent, the magnanimous Don Woude.
Woo! And he got his name right.
Did. Yes, owl or train as well. Single owl. But before we begin, we start every episode off the same way, don't we? Where we tell you a bit about us and something we've learned about ourselves. So, Joe, what's your fact for this week?
My fact this week is that my favourite comedian is Greg Davis.
Ooh, yeah. Love firing cheese balls at a dog.
I do love firing cheese balls at a dog. I love You Magnificent Beast. Anyone who's seen that show live, Pam can't afford it. It's just a hysterical skit. Yeah, he's very funny.
What I like about him is he's just so ridiculously large.
He's larger than life.
Oh, Mr. Taskmaster. Now,
Taskmaster.
I wasn't sure if I was mixing up Alan Davis and Greg Davis.
Oh no, Alan Davis is funny, but Greg Davis is just like Taskmaster's good, but his stand-up is just hysterically funny.
I think it's just because he comes across so jaded, as like being a teacher for so long is just sort of like you can see that it's had its toll on him.
Exactly.
And our friend Ollie, who you may have seen from our was it our Pain in the Curriculum episode? Yeah, from our Pain in the Curriculum episode, he's a teacher, and, well, if we give him probably another 10 years, he may end up as Greg Davis.
He's got a flourishing career as a comedian ahead.
He'll grow 5 inches, put on a lot of weight. He's already funny. He's already got the funny part.
Yeah, absolutely.
5 inches? No. Greg Davis is way taller than that, surely.
Ollie's 6'3".
No, he's not.
6'2", sorry. Greg Davis is 6'7".
Is he?
I feel like either I'm shrinking or our friend Ollie, who, as I said, if you go back to episode on Pain in the Curriculum, he is taller than you'd expect.
Yeah, he's just kept growing. He didn't stop growing until he was like 22. So, genuinely, he didn't. He just kept growing. Either way, you've learned a lot about him on these recent episodes. We keep bringing him up. We obviously miss him a lot.
Yeah, maybe we'll bring him in for another episode at some point.
If you want him back on the podcast, let us know. Josh, what's your fact about yourself this week?
Mine is sort of a bittersweet fact, but I will, after the next couple of weeks, because I'm moving on in my training, I will never have to do a medical job ever again.
Do you want to give a little bit of explanation of what you mean by medical job?
So I'm still going to be a doctor. I'll still be working in different areas of medicine, emergency medicine, which is my specialty. But the way that we do things is we rotate through different areas of specialty during our specialist training, and I'm finishing my medical rotation. So no more ward rounds for me, no more inpatients for me, just all acute stuff.
Yeah. Congratulations.
Thank you. I also take a big pay cut as well, so it's always a bonus.
Yay!
What will you be doing to celebrate?
I'm not doing a ward round. that is my celebration. So, Dawn, what is your fact about yourself this week?
My fact is that I have now embraced wearing hats. Not a design choice, more of it's come to the age of the hair loss.
Oh.
Yes. And so whenever I leave the house, I'm just like, where's my hat? But yeah.
What hat are you currently sporting?
So for a long time, I think before COVID, definitely before COVID, I had a fairly recognisable green and white stripy baseball hat.
You did? I loved that hat.
Yeah, I think I lost it. Or it just disintegrated because I wore it so much. And that was back when I did have hair. But now it is this cute little hat that I got from a shop in Sheffield called Plain Bear. And it's just a plain hat with a bear on it.
Is it a cap? Is it like a beanie?
It's like a baseball cap, yeah.
Okay.
Kind of like what Josh is wearing right now.
I am very tempted to put pictures of you with edited hats on the Instagram and see which one people think is the best type of hat for you. Because you've only tried baseball caps, and really you haven't expanded into trying out all the different types of hats.
What are those ones that old men wear, which got the rim around them all the way around?
A fedora.
A trilby?
No, not a trilby, not old men. I meant sort of like, it's floppy. You go to the beach and you're usually wearing sandals and socks.
Oh, like a sun hat?
Yeah.
Yeah.
I think that'd suit you.
I can see you wearing a sun hat. I could see you wearing a top hat.
Oh my God, I'd love to see Don in a top hat.
I really dislike this discussion because my dad wears hats all the time now, and they're just ridiculous. He'll wear like a flat cap to the gym.
He lives in Yorkshire. That's standard attire.
That's all we ever wear to the gym.
He's got his whippets and his ferrets too.
He's got a pair of trousers that you can fit several ferrets in.
Joe, go on, tell us what you've learned about yourself.
I have learned that my diagnostic methods, training to be a physiotherapist, are all just basically involve hurting people.
Physioterrorist.
Precisely. This is what physios often get called, because all we do is we're going to look, say we want to find out if something's wrong with your knee, we're putting your knee in all sorts of funny positions and putting you through like tests and physical activities that are designed to try and reproduce your symptoms. And 99% of the time, these patients that come in are coming in with some sort of pain. And so really, to work out what's going on, we're just trying to reproduce that pain to start with. But sometimes I reflect on it where I'm like looking, I'm doing a test, and then I see a patient flinch. And in my head I go, oh, good. Okay, that gives me a good idea. But actually, being on the other end of it is probably not very nice. So I've kind of reflected on that this week.
Oh, it's a good bit of self-reflection, yeah.
Yeah, my Instagram has now shifted, I don't know how, maybe it's just through knowing you, shifted into physio law, and the memes and the videos are
I'm
fantastic.
getting loads of physio memes.
Yep.
I keep sending them to Joe. That's probably why it keeps sending them to me.
Josh, what have you learned about yourself?
Yeah. What I've learned is I can really annoy Joe by not putting references in show notes. So for those that don't know, we typically write a loose script and we look at loads of research, put references in there. I have a very conversational style when I write episodes, which doesn't involve me studiously going through all the references I've used, much to the chagrin of Joe.
Because then I have to write the show notes, and it really takes a long time.
I'm sorry, Joe.
It's okay, I forgive you.
I can't change though.
Don, what have you learned about yourself this week?
I've learned that I might have acid reflux. Thank you for the diagnosis, Josh.
It's okay.
This is really completely separate, but you said the word diagnosis and it triggered like something in like 9-year-old Joe. Do you remember Diagnosis Murder?
Yeah.
No.
With Dick Van Dyke?
No.
It was like a how would you even describe it?
It was like Columbo meets House.
Yeah, exactly.
Okay.
Either way, if you're bored and you want to watch some mediocre TV from the 1980s, or maybe even earlier.
Diagnosis Murder.
Diagnosis Murder.
Was he a medical examiner? I can't quite remember.
I think so.
Dick Van Dyke and Barry Van Dyke.
Who?
Barry, his son.
Is Dick Van Dyke still alive? He must be like 110 if he is.
He is Father Time. Is he? Is he 100?
99.
Oh, go on.
Oh, I hope he gets to 100.
Well, Betty White didn't make it to 100. She only got to 99. I found that very sad.
It is.
She was only like 6 days off, I think. Poor old Betty. Either way, sorry. Yep. You've been diagnosed with acid reflux by Josh.
Yeah, because apparently I burp a lot.
Too
Or an
much.
unusual amount, yeah.
Yeah. See, that's it. The benefits of being friends with doctors. I'd hope to diagnose you with something.
Yeah, because the burping, it was getting to a point where it just felt really good to burp, and I don't think that's normal.
I mean, I don't. I quite enjoy a good...
You know?
If you've had a rich meal, it's quite nice to just...
Oh no, this is like all the time.
So, Don, do you know what the proper medical term for burping is?
No.
It's eructation.
Eructation.
Yeah.
I knew him well.
I currently do know him quite well.
I've never heard of that. What's the... Is that your favourite word for like a normal activity? So say, for example, like urination is micturition, is that right?
Micturition, yeah.
Are there any particularly good ones that people might not have heard at home?
There are lots. I'll have to think about a few.
Okay.
But
Listen to the breakdown.
yeah, absolutely. But back to today's episode.
So, Josh, you mentioned that we were covering arthritis this week. Haven't we already done that?
We did cover a small bit, like Josh said in the beginning, about axial spondyloarthritis with the fabulous Zoe Clark. But today we're going to be digging deep into rheumatoid arthritis, including the who, what, where, why, and what it does. And I'm going to just say, Josh has written these show notes, and I just read that sentence verbatim. We usually don't do scripted bits, but the fact that he's written who, what, where, why, and what, I think...
I think this might be one of his best scripts.
I agree. So arthritis covers...
How many different types of arthritis are there, Joe? A lot.
Well, I mean, inflammatory arthritis covers a wide spectrum of conditions, but there are some features that you'll have heard us talk about before on the podcast that come up again and again. So joint pain, swelling, heat of the joint, so you might feel like it's very hot to the touch, tenderness around the joint that's affected, and morning stiffness lasting at least an hour. Insert the joke there yourself.
Warmth. I think I felt that before, and I think it felt kind of nice.
What, having hot joints?
Hot joints.
Yeah. I mean, sometimes it's nice, like when you've been working out and maybe there's like a little bit of inflammation in the joint and it feels like warm to the touch, but it's not painful.
Yeah.
But when you see people with certain types of arthritis, like there are people who you'll feel like you'll feel their arm and they feel like cool to the touch. And then you'll feel their arthritic knee and it's
Hot.
It really hot.
Hot.
Like hot to the touch.
Yeah. So, I mean, we've already called axial SPA, as we've mentioned, and we'll take a deeper dive into the most common inflammatory arthritis, which is rheumatoid arthritis. And, well, the basics of it is that rheumatoid arthritis, or RA, is an autoimmune and inflammatory disorder. That means the body's immune system mistakenly attacks its own joints, usually the small joints in the hands and the feet. And over time, this can lead to chronic pain, joint damage, and disability.
Can I give you a little bit of an idea of where rheumatoid arthritis is thought to come from?
Oh, please, yes.
So we've got like a few sort of examples of art throughout the years where rheumatoid arthritis might have appeared in the 15th to the 17th centuries. And there's modern descriptions of it in the 1800s. But one of the theories based on archaeological findings is that the skeletons of ancient Amerindians, so living in the Americas 3,000 to 5,000 years ago, they're the earliest conclusive archaeological findings we have of skeletal changes for rheumatoid arthritis. And so there's one theory that says that when people went over and colonized the Americas, that the interbreeding actually then brought back rheumatoid arthritis. They suspect that this disease had never existed anywhere else outside the Americas until the kind of 1400s, 1500s. So they think that it's very similar to the way that syphilis didn't exist outside of the Americas until this kind of, in inverted commas, New World era.
Oh, wow, okay, that's really interesting. I didn't know about syphilis either.
So it's an STI.
And you have it. It's actually getting a lot more common, syphilis.
Is it?
Yeah, so particularly in the gay community, it's becoming more rampant. The reason being is we've got PrEP and PEP now. So people that previously would have used condoms whilst having sex, because they've got counts of 0 if they're HIV positive, which with a count of 0, undetectable means untransmissible. And with just PrEP and PEP, so pre-exposure prophylactics and post-exposure prophylaxis, it makes, if you did have unprotected sex with somebody that you didn't know, I'm not recommending this to anybody at home, it makes it somewhat safer. But what that has led is to a lot of unprotected sex in the gay community, and now we're seeing rampant syphilis. So yeah, it's making a comeback.
Josh and I don't know if Don has also watched it. Have you watched Scrubs, Don?
I have watched Scrubs, yes.
Did you watch it when it became terrible and moved to being a training hospital rather than, or just teaching medical students?
I think I watched it when I was about 13, 14, so it's been a long time.
Did that have Franco in it, Franco's brother?
One of the Francos,
Yeah.
yeah.
Oh, God.
And all I remember, the one thing I remember from that is whatever Franco brother it was going, syphilis! So there you go. Either way, back to it.
Yeah, I think the main thing people want to know about rheumatoid arthritis is what are the risk factors. So what is it that predisposes people to having rheumatoid arthritis in the first place? You know, like, why have I got this affliction? What have I done? Or what's been done to me to make this happen?
Yeah.
And I think, Don, we did ask you to have a look at the risk factors, didn't we? So
Yeah. So as with most things, genetics is a big factor. If you've got a first-degree relative, such as a parent or a sibling with rheumatoid arthritis, you're about 2 to 4 times more likely to get RA than someone without that kind of family history. And 40% of the risk of developing RA can be chalked up to inherited genes.
wow, so basically it's your parents' fault. To blame them.
As always.
But not all rheumatoid arthritis is the same. We've got something called seropositive rheumatoid arthritis. This is where patients test positive for antibodies like rheumatoid factor or anti-CCP. And this tends to be more strongly linked to genetics than seronegative types. So just to explain that a bit more, antibodies are those sort of proteins in your body that can find things for your immune system to attack. Okay? Yeah, so they're like the guard dogs of your body, really. And
Why did that sounded like if Voldemort was a dog?
yeah. So if antibodies if antibodies find something that looks foreign, they'll attack it and recruit lots of other inflammatory and immune cells to also attack it, and that's what causes that damage.
And so, yeah, these antibodies then are targeting things that are inherent to you. And so usually these antibodies attack things like Josh said, foreign things like infections. They attack things like if you got any sort of, say you got a cut and you got some mud into your system and there's gunk in there, there's bacteria, it's going to target that. Whereas the things that rheumatoid factor are targeting, and this other antibody Josh said, anti-CCP, they're actually targeting parts of your own body. So your body's accidentally switching its guard dog system against itself.
Yeah, exactly. And do you know what? Like, this is the basis of all autoimmune conditions, regardless of what it is. It's your own body attacking yourself. Why we call it auto. And we've already talked about the basic figure of how much your risk is increased with genetic factors. If you have a first-degree relative, that's mum, dad, or brothers and sisters. But another key genetic player here is actually HLA-DRB1 gene. Now,
Whoa, that sounds fancy.
It's me trying to make myself sound smarter than I am, Don. That's exactly where it is. But basically, what that is what we call a major let me get this right. Sorry, my tongue's tied. What that is it's called a major histocompatibility complex. This is a gene that helps the immune system recognize what belongs in the body. So, we got the antibodies that, as long as it looks like what they're looking at, they'll attack. Whereas this sort of tries to help us realize what it is we need to attack.
So if you imagine that you've got this sort of monarch sat on their throne, and they're a very evil monarch, and they like to kill things themselves. They're like, bring them to me. These MHC molecules basically pick up that foreign body or that thing that your body wants to kill, and they present it in front of the monarch, and they say, "Sire, you may kill the prisoner."
And the antibodies is the monarch.
No, the antibodies are the guard dogs. The antibodies are outside. They're doing their thing.
Yeah.
But this thing basically presents things to your immune system and goes, hey, you want to kill it?
Now here's where it gets really interesting.
Or depressing.
You decide.
When you mix genetics with environmental factors, things can really escalate. One of the strongest environmental triggers, I think this is quite a cool thing to do. No, I'm joking. But it is one of the biggest environmental risk factors for pretty much everything, and that is smoking.
And so studies show that people who smoke heavily and also have this genetic risk factor have a much, much higher risk of developing rheumatoid arthritis. And so that's kind of like a textbook example of what we would describe as a gene-environment interaction. So this is a perfect example of nature versus nurture.
Yep.
So that gene is the nature, that's what's already inherent to you that increases your risk, and the nurture, the choice you make to smoke, is that sort of nurture element. But also, the things that you do, the lifestyle choices you make, cigarettes actually do have mutagens in them, so things that cause your DNA in your cells to change. So that's what, for example, causes lung cancer, is that the cigarette smoke causes a change in your DNA sequence that then causes harm.
So mutagens, does that mean if I smoke I can become an X-Man?
I mean, I think if...
I'm more likely to be an ex-human.
Yeah, exactly. You're more likely to be ex-living.
That's quite funny.
But smoking also can change something called epigenetics. So when we talk about genetics, you might think of something called DNA. You might think about this code in our bodies that decides what we do, how we function. But actually, each of those little pieces of code can be further modified by little chemical structures that can be taken on or off that bit of code, and that changes how it's read. So if you imagine that you speak Spanish or French or something, imagine that these little extra molecules are like an accent over a letter. So it changes the way that it's pronounced, it changes the way that it's read. And so smoking can not only actually mutate your DNA, it can change the way in which it's read, and that can further trigger your likelihood of developing rheumatoid arthritis.
Yeah, and particularly with smoking, something that's fantastic and you should all know is that...
That is smoking.
Yeah, and the more heavy you smoke, the higher risk you have of developing rheumatoid arthritis. So, yeah, there's pretty much a direct relationship between...
Consumption.
Yeah, consumption and effect. So, yeah, I mean, there must be some sort of like golden ratio maybe, like between looking cool and getting chronic pain. But, you know...
I think the chronic pain makes it cool.
Yeah, that's
You could be
it.
like us.
Yeah.
But except we don't smoke, but you know.
But we're very cool.
I mean, yeah, it's dose dependent. So, I mean, it's a good thing like smoking isn't highly addictive, isn't it?
Yeah, absolutely.
This is a public announcement. Please do not smoke. If you smoke, I recommend that you stop, or please see local NHS services.
It's weird that the NHS services announcement was American, wasn't it?
Exactly. Well,
either way, smoking is not the only risk factor, is it, for rheumatoid arthritis?
so we've already talked about smoking, but there's also lower educational level,
High birth weight.
Obesity.
alcohol intake, ruh-roh.
Silica dust. What is silica dust?
Is that the little things that dry out?
that you get in
packages?
like when you buy a new
Yeah. So
piece
it's
of technology or something?
Yeah.
So it's a lot in industry. So like silica, if you think about making like chips for computers, smartphones, that sort of thing, and it does cause like inhalation of silica dust does also cause one of my favourite conditions, which is pneumono ultramicroscopic volcanosiliconoconiosis.
So
Is that just your favourite because of the name?
It's very long and hard to pronounce.
Okay, excellent. Is that one of the longest words?
Yeah, it
is.
is.
That longer than floxinoxynihilopolification?
It is longer than floxinoxynihilopolification, yeah.
Wow.
Why is volcano in it?
Well, it's just because of the silica. I don't know.
Oh, fair enough. Yep, I didn't put those two dots together.
Oh, okay, that does make sense. Because
Yeah.
I was just like, I thought it was just someone was naming it, and they were like, okay, just
Pneumo-
sneak a word in there.
Right, we've got pneumono ultramicroscopic volcano silicosis. Yeah, it's shortened to silicosis for obvious reasons.
Okay, but it's speaking about industry as well. Air pollution as well
Absolutely.
is a potential risk factor for rheumatoid arthritis.
So I wonder if we see higher rates in places like Paris, London, those like.
I think you see higher rates of everything in London.
We do, yeah, indeed.
We'll have a look and we'll tell you on the breakdown.
Yeah, and certain solvents as well can also predispose to rheumatoid arthritis.
Interesting UV light can as well.
Ooh, okay. I suppose it's that sort of breakdown of healthy cells, isn't it? You'd think so. Maybe
Possibly.
that mutative effect that you was on about. I
Could
don't
be.
know. Anybody knows at home or is an expert on that? Please let us know.
Right in.
If you're an expert on UV light, I'm a bit concerned. What are you doing with all that UV light? Gardening. It's great for gardening, I've heard.
Is it?
I don't know, I just made that up.
I mean, one of my favourite things, well, not favourite things, but one of the things I find most interesting, because my previous degree, which is biomedical science, but with a big focus on immunology, is that actually certain bacteria and bacterial infections, Joe did sort of point towards this earlier, but if you have periodontitis, so that's inflammation of the periodontium within the mouth.
Can you just specify what periodontium is, please?
Yeah, absolutely. So the periodontium is just basically the toughest structures that support your teeth in place within your mouth.
The gums?
Yeah, well, effectively, yeah.
Okay.
So there's a bacteria. It sort of sounds like gingivitis. It's Porphyromonas gingivalis, and it contains a protein that converts part of your body into something that your antibodies can recognise and think is foreign. So previously, healthy cells, which look completely normal, appear to the immune system to be a threat.
Dun, dun, dun.
Doo-doo-doo.
Josh was talking about bacteria last night, and was, we have thrilling conversations on our recording weekends. No, he was saying that I think a lot of people know this. We've been dropping a lot of interesting facts that most people know on the podcast recently. But obviously there's 10 times more bacterial cells in your body than there are human cells. And I think pretty much every time we research a specific condition, we always find there's some bacterial link in there.
All right. What are some other factors? I think lower socioeconomic status.
Do you want to talk about why that is? Because I think sometimes with risk factors like that, people can be like, well, why would that increase your risk of developing it?
Yeah, it's not just, So it's possibly due to the reduced ability for people to work, and so their income is affected by that.
Because of the symptoms?
Because of the symptoms. It could also be due to delayed presentation to a clinical practice, so seeking help, and limited access to healthcare, and an increased likelihood of smoking, and nutrient deficiency and higher BMI, a lot of things.
So basically, it's lower socioeconomic background is one of those catch-all risk factors, just because you're at high risk of other environmental risk factors as well.
But thinking about all of these risk factors, who is most commonly affected? So when you're thinking about, if you're listening to this, for example, and you think, oh, well, like one of my family members has rheumatoid arthritis and I actually do smoke and whatever, but you're 20 years old, you're not really a good fit for the likely presentation. So how common is it? Who is it most commonly presented in?
Yeah, so the most commonly affected groups are those between the ages of 70 and 80 years old.
Yeah, I've got a few years of me.
Yeah, you've got a few years left on. And it's twice as common in women as in men. And that seems to be quite a common theme with a lot of autoimmune conditions, that it's more common in women than men. And the prevalence, when we look at, for example, Europe and North America, is roughly 0.5% to 1%, so like 1 in 100 to 1 in 200 people. Obviously, different geographic locations vary within that cohort, but yeah.
So then, if you're having this individual who's come in, Josh, you've got a 70-year-old woman and some of the... You've got a 70-year-old woman who comes in and they're complaining of sort of pain and maybe in their joints. What would you do to diagnose rheumatoid arthritis? What are you looking for?
Yeah, so I mentioned this before, but taking a good clinical history is key to this. Rheumatoid arthritis is primarily diagnosed based on clinical symptoms. So think joint pain, stiffness, especially in the morning.
Morning stiffness.
Swelling. Also more common in the morning. But doctors use lab tests as well. We don't just see somebody with swollen joints, which are a bit stiff in the morning, and then instantly diagnose. We do need to do blood tests.
So what are you looking for in the blood tests?
So we look for those antibodies. We've mentioned those. Those are the things that we see in the blood which attack our own cells. So for one, we look at rheumatoid factor. The clue's in the name, isn't it? It's a protein that's released when somebody might have rheumatoid arthritis. And this is found in roughly 60 to 70% of patients with rheumatoid arthritis.
But it's not very specific. It can actually show up other diseases too. So you might have heard of lupus or Sjogren's syndrome. Sometimes it can show up in them as well in patients who don't have rheumatoid arthritis.
Or fit the bill of someone who would typically have it.
Exactly.
Such as Venus Williams, tennis player.
Yeah, famously had Sjogren's.
Interesting. Is she RF positive, rheumatoid factor positive? Do we know?
I don't know her medical records, but she was just somebody who I instantly thought of when I saw Sjogren's.
Interesting.
Yeah.
But that's not the only thing we look for, right, in these blood tests?
No, absolutely not. Like, even if you've got a negative rheumatoid factor, we look at something else which is a bit more specific, which is anti-CCP antibodies. So
You've heard us talk about them already in this episode.
Exactly. We don't need to go into great detail about those, but they are actually a lot more specific when it comes to rheumatoid arthritis. And they're present around about 70% of those with rheumatoid arthritis. So, if someone's rheumatoid factor negative, but they're anti-CCP positive, doctors are still thinking, okay, yeah, this could be rheumatoid arthritis, even though you've negative for the one that's got rheumatoid in the name.
And it's not just like these antibodies that we're looking at. We can also look at general inflammatory markers. So you've heard us talk about these before on the podcast. CRP is like a marker of acute inflammation. So inflammation in the short term, say that you've just smashed your toe into a door, like you would have raised CRP in that area. And then ESR, which is erythrocyte sedimentation rate. You don't need to know what that is, but basically it's a marker of longer term inflammation. So if you've got persistent inflammation in a joint like arthritis, you might have this raised level of ESR. So it can help you to potentially identify not specifically rheumatoid arthritis, but an inflammatory condition.
Yeah, and alongside those bloods that we can take, we can also do imaging. So X-rays are the fundamental basis of pretty much all investigations for joint pain. And you can also use ultrasound. Now, from what I can see, BMA Best Practice, which is a website which keeps you up to date on what's modern and what type of investigations we would use, suggests that ultrasound. So that's the same type of scan you'd do if you was checking for a baby. But I'll be honest, I've never seen that actually used in practice. And from what I can see, it's not in many trusts' guidelines. So I can't see any hospitals really that do that. It's more of a specialist thing. So like it wouldn't be me in emergency medicine, despite how much I love using an ultrasound probe. It'd be something a lot more specialist, like your rheumatologist that would be booking that.
Okay.
So Josh, you mentioned X-rays as well. What would you expect to see on an X-ray?
Yeah, absolutely. I'll tell you what, should we get some X-rays up? I'll show you them, and maybe we could pop them on our
Instagram?
Pop a couple. We'll make sure that they're non-identifiable. We'll find them all using Google or Radiopedia, which is a good resource for doctors.
Yes, please.
Yeah, so we'll share this image with you. It's freely available. There's no identifiers. But what we can see is the distortion of the hands, the joints, the fingers, and we can see...
I think that might be my mum.
Could be, potentially could be.
Her fingers are very much like that.
Are they actually like bent off to one side?
The end of her like middle finger and index fingers are like at 45 degrees.
That's crazy.
Wow.
Yeah.
And we can see the erosion of the joint spaces as well. We'll highlight this on, not our Patreon, we think we should be able to see this freely.
We could even do a little bit of a live video. We could put up a video of you talking people through those key features so people can have the full idea of what they're seeing.
That definitely needs a visual aspect to it rather than us just discussing that.
Absolutely. Yeah. Do you mind if I just briefly explain how these joint erosions work?
Please. Yeah, I'd love you to.
So you've got two types of main cells in your bones. You've got osteoblasts. So these are ones that help build new bone. So blast, B for build. And osteoclasts, which help to break down. So C for...
Catastrophe.
Collapse, catastrophe,
Yeah.
crush. They're the ones that break down the bone. And
I'm never forgetting that one.
I've made it so easy to remember. But basically, within rheumatoid arthritis, this inflammatory environment causes more activity of those osteoclasts than of the osteoblasts. So you're basically breaking down the bone faster than you can form new bone. Because healthy people, your bones are constantly turning over. You're replacing old bone, making new bone. But in people with rheumatoid arthritis, it breaks down faster than it's made. And so that's why you get these kind of erosions of the joint space and you get little bits of bone that basically wear away.
Yeah. I think this is a good point to put this in, but do you know like, what models are done?
Really skinny people.
No. I'm talking about scientific models.
Okay.
So these are things that we use as a sort of alternative to using humans to test diseases. So it could be a lab rat, it could be cells in a dish, it could be anything.
A guinea pig.
Guinea pig. The way that we make models, or the way it was when I was taught several years ago, is that we can get mice and we can make them have arthritis, rheumatoid arthritis specifically. And the way they do that is, sounds quite cruel, and it is quite honestly. So what they do is they actually get a syringe and they inject some collagen, so typically type 2 collagen, into the rat's joints. So collagen is a protein that helps to make up bones and articular surfaces, so where your bones go next to each other and get smoothed out. And this causes the autoimmune cells to start attacking those cells.
Which cells? The collagen ones?
The collagen ones, and then, then your immune
Interesting.
system starts attacking it. So then you give mice,
You're
rats,
inducing
rheumatoid
RA.
arthritis. Yeah, so don't inject type 2 collagen into your bones, guys.
Also, speaking of taking collagen, when people are
Which is a
buying-
huge trend now.
huge trend, all these fancy creams that people put on their skin, just a little piece of like sort of word to the wise, the only chemical in any of these creams that has the like capacity to get through deep enough into your skin to actually have a positive effect is hyaluronic acid. Everything else does not have the ability to penetrate your skin deep enough to actually refresh it. So I'm not saying don't put creams on. Like if it feels nice, if it helps to soften up your skin and gives you a barrier cream and it feels nice, it relaxes you, whatever, great. But if you're talking about like anti-aging and things like that, and you actually want to benefit the health of your skin, hyaluronic acid is the only thing that gets deep enough. So rather than wasting your money on these fancy creams, waste your money on very specific fancy creams.
For fuck's sake, Joe, you've just ruined my collagen cream business.
Yeah, I mean, Q10, that traditionally was pushed, wasn't it? But it works, definitely works. It just doesn't penetrate deep enough, as you said.
Exactly. So if you could get it there, if you like flayed yourself and then put it on the deep layers of skin, then it would be fine. But obviously, we would not recommend that here.
Yeah,
at Pain
please
in the
don't do
Podcast.
that. Yeah, nice.
Why are the mice always like the white albino kinds?
Because they're all clones of one another.
Are they?
Genetically, so they've bred them so that even the males and the females have the exact same genetics.
And can you just order them?
Yeah.
From.
You literally just order them from a catalogue.
Wow.
You say, I want this mouse, and it's got its full genetic profile, tells you what it has, what it doesn't have. It's a weird thing. But it means that you can get consistency in your results.
Yeah.
So, because if you test two mice and one of them a drug works and one of them it doesn't, and they're completely different mice, it might
Yeah.
be a genetic response.
I have a question. With the osteoclasts being more prevalent, and kind of destroying the bone structure more,
Yeah.
what does it turn that into? Where does the residue bone material end up?
So, it gets eaten up by immune cells called macrophages. So they're basically like the body's hoovers. So they go and they just kind of gobble up all the residual bits. But also some of that calcium gets released into your bloodstream and gets taken up in other parts of your body. But actually, interestingly, this increased inflammation in rheumatoid arthritis causes more calcium deposition in your arteries and in your veins. And so you might not realise the importance of this as a listener, but actually deposits of calcium can be key for forming clots. And so that's why people with rheumatoid arthritis have a 48% higher risk of strokes or heart attacks. 40% of their excess mortality, so the people who die with RA compared to a healthy population, 40% of those extra deaths are due to cardiovascular disease.
Yeah, absolutely. And this is something that we look at when we're risk stratifying and deciding how aggressively to treat. So what we'd call those are extra articular involvement. So that's things that aren't articular, so not in the joints. So as Joe mentioned, that's issues with the cardiovascular system. That can be issues with the skin. It can be issues with the eyes.
And just a couple of particularly important ones. So we've already mentioned that higher risk of cardiovascular disease. Interestingly, depending on study you read, between 33 and 60% of rheumatoid arthritis patients have anemia. And this is thought to be maybe because they use these non-steroidal anti-inflammatory drugs, which can cause a little bit of disturbance to your gut, basically, and they can reduce your absorption of iron. So people end up anemic as a result of their rheumatoid arthritis. But Don, I think you found that's not the only kind of, like Josh said, there's a lot of these non-joint presentations, aren't there?
Yep. And one of those is asthma. Asthma is twice as common in RA patients as in the general population. And this could be due to bronchiolitis.
What's bronchiolitis?
So bronchiolitis is the inflammation of the respiratory system,
Okay. Yeah.
specifically your bronchioles.
Okay.
I don't know what those are.
So is that going to be then, this is just me guessing, and you guys can tell me if you think I'm on the right lines here, is it going to be that your whole body's in this more inflammatory state, and so that's impacting on your lungs as well?
I don't actually know. Yes, that seems to be the thing of it.
Because there was one paper that said that 20 to 30% of RA patients actually have a lung symptom before they ever have a joint symptom. So it seems like there must be something systemic going on here where your whole body has higher rates of inflammation.
Yeah, and also just linking back to bones, we actually see that roughly, what is it, about 2 out of every 7 patients also have osteoporosis.
Yeah, and as a result of that, patients with RA have like a 52% higher risk of fractures compared to the general population. And so I think that leads us perfectly on when we're thinking about people developing fractures, thinking about falls, for example. RA has a lot of functional limitations. And so if you've got to imagine the main places that this affects, it affects the joints in your hands, so sort of those joints where your knuckles are, it affects the joints above your knuckles, kind of those first folds in your fingers. And if it's causing these joints to have reduced mobility, it's putting them off at funny angles, it can be really hard to write, for example. I've worked with a few rheumatoid arthritis patients who can't hold a pen. They really struggle to type. They struggle to hold cups and glasses. And you think, oh, well, someone can help them. But bear in mind, the maximum level of conventional carer support that you can get in the UK is 4 times a day carers. So you imagine that people are coming in every 4 hours of your waking hours. Now, that's not very often. Say that you need a drink and you have the physical inability to take the lid off a bottle or to pick up a cup. Obviously, yeah, you could put it on the side and put a straw in it and you could bend over and drink from the straw. There are solutions, but it is massively functionally limiting. And again, it can also involve the feet as well, where people have altered foot shape and they have sort of their toe pointing off at an angle. Again, it can alter your balance, it can alter your walking. Functionally, this condition can have a whole host of sort of life quality limiting effects.
Absolutely.
Yeah, that sounds pretty devastating.
Yeah, so we've talked about functional limitations, we've talked about extra-articular involvement. There are other things that we look at when we're trying to stratify how aggressively we treat. So we look at whether there are those antibodies present, so anti-CCP, rheumatoid factor. We look at the imaging, so we look at how damaged the joints physically look when we're looking at the x-rays. That does impact us. I've mentioned in other episodes that we actually care more about the functional limitations, pain, and the person's perception as opposed to what those images are. But you can't reverse the damage that's already been done. So we need to get ahead of it before that damage does take effect, because that is permanent.
I want you to, listeners, keep that in mind when Josh says you can't reverse the damage that's already been done, because when we talk about treatment, there's going to be something very interesting we can talk about there.
Ooh, okay. So, when we're tracking rheumatoid arthritis over time, we need sort of a objective way of doing that, or a more consistent way of doing that. So, we use many different activity scores. These are scoring systems which encompass joint counts, so how many joints are affected. They include functional assessments like the HAQ or Health Assessment Questionnaire. We look at pain scores. So when you come to us in clinic, we ask if it's was it 7 out of 10 last week, and now it's an 8 out of 10. So we see it's getting worse. And one of the things that I found most interesting is patient and doctor impressions. So effectively, does your doctor think you're full of shit when you say you're in pain?
That's hilarious.
I'm talking out of pocket there. No, what it is though, subjectively, when the doctor's looking at you, do you look unwell? Do you look like you're managing well? Or do you look like actually you're really not managing on the regime that we've got you? That's where it boils down to.
Do you struggle with that?
The thing is, I have to take patients at the word. If they tell me they're in I'm in 10 out of 10, doctor. It's the worst pain I've ever felt. And then I always like to observe my patients before I go and see them, see what they're doing.
With your binoculars,
Exactly, yeah, from around the corner. Twisting my moustache. No, but if they're sat there looking very comfortable, having a coffee, playing on the phone, and then when I go see them, they're completely different, saying, writhing in pain. I mean, I err on the side of believing all my patients when they tell me the pain score and act from that, but subjectively they don't look like they're in a lot of pain. Whereas you get the opposite end of the spectrum. You get patients say, "Oh yeah, it's okay today," and then every time you walk past the bay, you can see that they appear to be in a lot of pain.
Yeah, that they're wincing, that they're waiting, they're counting down the number of minutes till the next time they can have their medication. There are some obvious signs that people are really struggling.
Yeah, and that's not to say that it's just doctor. You have to convince your doctor. As doctors, we're very sort of in tune with that sort of thing. Mm. So you don't have to try and play things up. You don't have to play things down. Just be yourself and just have an honest and frank conversation with your doctor, really.
Yeah. Is there anything else that determines sort of how aggressively this condition is treated?
Yeah, absolutely. So one of the main things would be things like the CRP and the ESR. So those are the things that we talked about earlier, which are monitors of both chronic and acute inflammation. So if your ESR, which is that chronic inflammatory marker, has suddenly gone up massively, like it's tripled in the last couple of months since we've last seen you, it shows that potentially the disease activity has increased, so we need to do something, because it looks like that damage to those joints, which are permanent, as I've mentioned, could be getting worse. So we do need to knock it in the head. And the common tools that we use, there's a C dye, there's the S dye, rapid free. My favourite seems to be the DAS28. That's one I got taught in med school. And they have thresholds for low, medium, and high sort of severity. And I'd like to take a minute, just sit right there, tell you how I became the prince of a town called Bel Air. I'd just like to show Don and Joe these DAS28s, and we'll share this as well, just because I think it's an interesting drawing.
What the heck?
Oh, the number of joints affected. Yeah, I've seen these.
Yeah, so it's the number of joints affected. We look at, well, there's 28 joints effectively, so that's all the joints in your hand, all the joints in your feet, your knees, your shoulders, elbows.
For the listeners, it looks like a normal diagram of a human being, but where the hands should be, it seems like it's been replaced by giant foam fingers.
Yeah, exactly. Massive hands. They'd be able to just palm a basketball easily.
Yeah.
They'd be able to use their own hand as a chair.
Like their hand is
covers your bottom chair.
Yeah, their hand is nearly 2/3 the size of the lower body.
Yeah, and that's just because there are so many more joints than the hand, and they're typically affected in rheumatoid arthritis. So that's why we use that as opposed to anything else.
Interesting.
That's quite interesting. Yeah.
When you are a patient, if ever you get access to your own notes, or you decide that you want to kind of move, for example, you're moving areas, one of the key things is to try and keep consistency. It really helps your healthcare professionals to work out what's going on. So say that you've been using one of these particular measures, so you've been using your DAS28, or you've been using a particular functional assessment. If you go to a new area and they change the tools that they're using to measure your disease activity, they change the tools they're using to measure your function, it's really hard to compare them. It's like comparing apples and pears. And so if you've got access to your old medical notes and then you move area, encourage your doctor in the new area to use the same measures, because it helps us to track in a more reliable way whether your disease is staying the same, getting better, getting worse.
Yeah, I can't disagree with that. That's very good advice.
He fundamentally agrees.
I do.
But Joe, from my experience, it's kind of difficult to know what methods the GPs are using for that kind of thing.
So the nice thing is that you, through the NHS app now, can access many of your medical records, but you also have the right to request all of your medical records. It is your personal data, and under data protection legislation, you have the right to request access to any of these, and provided that there is no reason, no defensible reason why that should be kept from you, then they cannot keep it from you. So say, for example, that on your notes, something had been written accidentally about another patient, for example. Obviously, that would be a reason not to share the notes with you. But there are very, very few reasons why your healthcare professionals wouldn't share the notes with you. So if you feel like you're wanting to move area or move practice, ask your doctors to provide you with your notes so far, so that you can show your new doctors and say, because often, unfortunately, the NHS systems aren't very well joined up. So it can mean that the computer systems in one GP practice are very different and can't access the computer systems of another one.
Yeah, I get that happening all the time in my hospital, particularly when people come from what we call out of area. So if not within the same area, so if you come from Scotland, if you come from the northeast versus me down in the east of England, like, I can't see GP records. It makes it very difficult, and there can be a delay in that information being transmitted. So if you have a flare in the meantime, in the interim from moving, you're out of luck. But there is some good news, and that good news is that when we do track these disease progressions, it allows us to adjust treatment based on what's happening to you. So how you're developing, or how well you're doing. We can even titrate medications downwards if need be.
Yeah, I mean, that is good news. It's good news that there's potential for this disease to be well managed if all the ducks align. No. Stars align, ducks are in a row. Ducks don't align.
I think the important thing is to know is that rheumatoid arthritis isn't just about sore joints. It's a disease that can affect your ability to work, your quality of life, and even your lifespan. We've talked about those extra-articular manifestations, many of which can affect your lifespan. Patients with rheumatoid arthritis who receive early and aggressive treatment typically have a favourable prognosis, with many achieving effective disease control and maintaining long-term joint function. So, the earlier we treat you, the more function you have, the better outcomes you have, the less pain you have.
Whereas if the disease is delayed in its treatment, then this really changes the outlook for patients. So if you're having some of these symptoms listening to the podcast, get checked out as soon as possible, because many of these patients will experience progressive disease if they're not treated, and up to 50% can become disabled within 10 years.
But beyond just joint issues, untreated RA is also linked to increased premature mortality, with the leading cause of death being coronary artery disease, a result of chronic systemic inflammation contributing to cardiovascular risk. So that's why early diagnosis and timely treatment with DMARDs are so critical. What are DMARDs, Josh?
Yeah, so that stands for disease-modifying anti-rheumatic drugs.
Cool.
It could be something as simple as NSAIDs, which we've talked about a lot. So it could be something as simple as ibuprofen.
Yeah.
So it decreases inflammation, decreases that damage. But for patients with low disease activity, guidelines from the American College of Rheumatology and from also NICE guidelines, ones which we use in the UK, they recommend starting with a single DMARD. So that's most commonly hydroxychloroquine. And it's got good tolerance and it's quite safe to use as well.
What's another option, Joe?
So sulfasalazine is another option, and this is commonly chosen as a trade-off. There's another drug called methotrexate, which you might have heard of. It's used in multiple different conditions and can even be used in cancer treatment as well. It's more potent, but it's usually given in more active disease, but it can have quite severe side effects. So it's that balance between hydroxychloroquine, sulfasalazine, or methotrexate, depending on how well your symptoms are being managed.
Yeah.
Which one did you say was also used in cancer treatment?
Methotrexate.
Ah, okay, interesting.
Yeah, methotrexate is a nasty medication. We typically don't give it to women unless you can prove you're really not going to have babies, effectively.
Oh, what? So does it change your fertility?
No, it's teratogenic.
What does that mean?
Oh, wow.
So that means it causes, effectively, it affects the fetus in utero. So it can cause congenital abnormalities, it can cause miscarriages, there are a whole host of things. For example, do you remember thalidomide? Well, you don't remember thalidomide, but you've heard about thalidomide, right?
Yeah.
That caused congenital abnormalities, which resulted in shortening of limbs and prolonged disability from that.
Yeah, and so the sort of indelicate term that's maybe used in the media, you might have heard people speaking about kids with flippers. That was kind of the presentation that kids were having, was they had these sort of limbs that hadn't developed properly that did have the appearance of effectively flippers.
Yeah, so I could be mistaken here, but I believe that women have to prove to be using two different contraceptive methods.
So what's that? Mayonnaise and Marmite? Is that right?
Condoms, intrauterine device, that
Reading
sort of
to children.
Welcome back to episode 1, everybody.
No, but on a serious note, they have to have two contraceptive methods. So that could be using condoms, that could be then having an intrauterine device, get regular pregnancy tests. And if it's a man that's having methotrexate, they have to effectively sign a contract to say that they won't conceive.
Really?
Oh.
Yeah.
So it can affect...
It's just there's such horrific effects from taking the medication and the risk in pregnancy that you even have to wait, I think it's even 6 months to a year after you've stopped taking it before you can even consider conceiving.
Wow.
Yeah.
I do want to point out, though, we're saying all these horrible side effects. DMARDs can significantly reduce those risks of bone erosion, of joint damage, and of disability. So this isn't like... These side effects are balanced up against the positive effects that they have. But if these aren't working, then there is sort of another level of drugs. And we will go more into these in a full episode on it. But I think it's worth just discussing things called biologics. And so they target a particular protein called TNF. And I think, Don, you found out about the sort of positive effects that these drugs can have.
Yeah, so anti-TNFs, anti-tumor necrosis factor biologics, significantly reduce disease activity and CRP levels and halt bone loss. But they don't seem sufficient to trigger new bone formation, so they're not quite making up for that.
And so this is what I mentioned briefly earlier on, saying that as much as these medications are very good, like Josh said, the changes at present aren't reversible. So it's important we catch this disease early. In fact, some of the studies I've read about biologics say that when people have their first rheumatoid arthritis symptoms, they can start to develop bone loss within 8 weeks. So when you start to have these like sort of systemic inflammatory symptoms, get to your doctor straight away.
Yeah, so interestingly enough, not interesting, maybe for this podcast actually, yes it is. So I'm suffering from some back pain. I went to see a rheumatologist, and during my first consultation with them, they give me a leaflet talking about a biologic medication, because they effectively, I can read through that in my own time, and then from the second appointment, if it's proved that I've got an inflammatory arthritis, for example, they can start it straight away. And that's so that there isn't any further damage to any of the joints.
Yeah, it's quite proactive.
It is, yeah.
It is. But if you're transitioning from these sort of like, I'm going to say more gentle, these lower activity DMARDs, so the things like the hydroxychloroquine, sulfasalazine, up to these more kind of aggressive anti-TNF drugs that Don spoke about, sometimes there are other drugs used to bridge the gap a little bit, and the guidelines vary on what they suggest about this. But Josh, what can be used to kind of bridge the gap?
Yeah, so what we can do is we can use something called glucocorticosteroids. These are steroids which have a very strong anti-inflammatory action. We can use those when tapering between different DMARDs, but we need to get you off these as quickly as possible, because what happens is, in a healthy person who's not taking steroids, we're not talking about anabolic steroids, we're talking about steroids that your body naturally makes. Your kidneys have adrenals on them, yeah? And they produce the steroids. When you artificially give your body the steroids, your kidneys get lazy as fuck. Your adrenals like, oh, well, we've already got it. Why would we need to make more? So they stop making it.
Interesting.
Yeah, so if you're on it for a long term, I'm not talking about if you have a few doses, I'm talking if you're on it for weeks, months, okay? If you suddenly stop that, your adrenal glands then can't catch up, they can't produce enough, and you go into something called, you've got something called adrenal insufficiency, and you can go into something called Addisonian crisis, which is life-threatening and you need immediate medical attention. Which is why if you're on long-term steroids, you'll be given a card and you'll be educated on this. Like this is like a known complication, and is, when I say a medical emergency, you're probably better off having a heart attack than having Addisonian crisis.
And this is why it's really important, if you are ever in a situation where you've got an inflammatory condition and you're using steroids. Some people report, I know people who have reported to me that the steroids was the most symptom relieving thing that they had, and they're like, why can I not just be given these all the time? Well, there you go. That's why they are not used long term. So just to give you that context to it.
So would that possibly lead to a kidney transplant?
No, not at all. What it means is we'd have to resupply you with steroids, and then we'd have to slowly taper them.
Right,
so we'd give you emergency doses. So if you're on long-term steroids and you're unwell, for example, so when you're unwell, you have an infection, your body is working harder than it normally does, but you don't have the ability to increase your natural steroid production, which help when you're unwell. We actually advise you on a sick day rule where you increase the steroids that you're taking. Okay, so that's how we do it. So if you come in Addisonian crisis, we treat you with steroids, we get you stabilised, and we go from there.
What if I came in with an Amazonian crisis?
Well, we'd get Jeff Bezos on the phone and say, "Oi, quick, we need a parcel."
Medication, though, we've spoke about, that is the mainstay of management in rheumatoid arthritis. And you might have heard us here on the podcast umming and ahhing about the value of medications in chronic pain. Inflammatory arthritises are best managed by medication. However, that is not the only way that they're managed. I obviously have to stick up for my very soon-to-be profession here. Therapy can be really valuable. So helping people to use splints to maintain their hands in good positions to prevent this kind of shifting of the bones, helping
Joe
people to
meant physiotherapy specifically, not any other kind of therapy.
I did.
Also, therapy just in general is good.
Yes, I agree.
But things like stretching and strengthening can be used alongside this splinting, and they can successfully improve hand function. So again, like I say, if you can help this person to maintain the ability to pick up a cup, to dress themselves, to wipe themselves after going to the bathroom, it sounds silly, but it makes a huge difference to someone's independence.
Imagine your DAS 28 after that.
I know, right? It'd be so improved. You'd just have giant hands with no issues.
Yeah.
But then, yeah, exercise also can produce small decreases in pain intensity. So it is worth encouraging these individuals to remain active, to keep those joints functioning. And also, weight-bearing exercise is the most valuable thing for promoting new bone growth. So if you're struggling in the first place to grow enough bone, you're having these erosions, doing as much as you can to stay active, to trigger that new bone formation is going to be important for slowing the progress.
Yeah, and just want to put a point in. I may have mentioned it before, but resistance training at any age, regardless of what age you start it at, is beneficial.
Absolutely.
So even if you've never picked up a weight, and we're not talking about going to the gym, lifting 200 kilos and then screaming and dropping them on the floor and doing whatever else you might do. Even if it's as simple as a couple of kilos, some
Tin of
bicep
beans.
curls, tin of beans, some squats, all from the comfort of your own home, it's going to be beneficial.
Absolutely. And there is a wonderful wheelchair boxing coach called Louise Fay, who runs a company called Chronic Warrior, Chronic spelled Kronik, and she basically does adaptive sports sessions, not just adaptive boxing, but adaptive workouts as well for people with disabilities, with physical limitations, and she's phenomenal. And she does a free class every Thursday online. So if you're wanting to get some of that social engagement, wanting to do a bit of resistance training, wanting to have someone who can adjust exercises for you and make them within your physical capabilities and your stamina capabilities, there is no better place to start than with Louise. And also all of the stuff that she does, she gets grant funding for. That's what keeps the organisation going. So if you do decide to go, or you decide to give it a look and you feel like it deserves a little bit of a thank you from you, I know that donations are always really valuable there to help keep those sessions free for everyone.
Yeah, Louise is fantastic. She's got such a great personality for that as well.
Absolutely does.
She's so bright and bubbly, but also really gentle and encouraging as well.
But also, alongside being gentle and encouraging, she has an absolute cannon of an arm.
Oh, she's just insane. Yeah,
Absolute
badass.
God, she can produce so much force with her punches.
Yeah.
Thankfully, I've not been on the receiving end. I've only seen a bag on the receiving end. But geez.
No, yeah.
Yeah.
This plug has actually been forced. She's stood here right now. She's threatening to punch Joe. Please send help.
Blinking furiously.
But there is. Beyond exercise, there's one other thing that we found that seems to be able to improve symptoms in arthritis as well, wasn't there?
So this one is a bit controversial, and I'm pretty sure Josh isn't a big fan of this, but he can express his own opinions. Acupuncture, combined with disease-modifying drugs, has shown evidence to outperform treatment, which only consists of disease-modifying drugs. So yeah, I think the assistance of acupuncture has come in handy there. But Josh, do you want to give your input on that?
Nope.
Okay. He fundamentally disagrees.
But I think I know some people who are very big into like this idea of like unblocking of chi and stuff, this conventional idea of acupuncture. I know some doctors who say that if you stab a great big needle in your foot, you forget about the pain in your back. To be honest with you, whether there's an obvious scientific mechanism or not, if it's gone through a rigorous trial and has worked without any adverse effects,
If it works, it works.
Exactly. If that's in a way that doesn't harm people, then I'm a supporter.
Okay, so we've had a good overview there of what rheumatoid arthritis is. We've talked about how we can recognise the signs of it, how we can investigate it, diagnose it, how we monitor it, and we've briefly gone into treatment methods and the medication surrounding it. I hope that's give people at home a good overview. If you feel like, oh my God, this resonates with me, I do have swollen hands that are stiff in the morning, I recommend seeing your GP. That's the first step for anything like this at all.
If your fingers are starting to curve slightly,
Yeah, like there's some deformities. We can put those on our Instagram. We can show you a couple of things that might be the things that we can't really show you when we're talking to you. I can describe it, but that doesn't. A picture paints 1,000 words, is what I'm trying to say.
It's a shame you listeners don't get to see Josh, because he's very animated sometimes, especially with his gestures.
He's not real. He's a cartoon. No, he is very animated with his gestures, isn't he?
Yeah. So, if you'd like to support this channel any further, we do recommend, we've got Patreon.
We do indeed.
We do. We've got some extra content on there, including I think we might have some videos coming up soon.
We most certainly do.
Ooh, nice.
Keep your eyes peeled for them. We've got tons and tons of stuff on there. Now I think we're at like maybe 40 or 50 different pieces of content on there. It's it's full. So you're not just...
Starting to get value for money now.
You really are. And it's just, and I say just, £3 a month.
It's a cup of coffee.
It is a cup of coffee. And even if you decide to do it for just 1 month and then to unsubscribe, even £3 does a world of good for paying for our petrol and train fares to come and record these episodes.
Yes, I mean, yeah. Look, if you're struggling for money, don't do it. That's fine. All the content is great that we've got that's without a paywall.
But tell your rich friends and then just sit with them while they watch it.
We'd much rather you like and watch every episode.
We'd much rather you have rich friends.
Yeah, so with that, I think we come barreling towards the end of the episode. But last but not least, we will have our book review this week.
What's it going to be, Joe?
It's going to be The Painful Truth by Monty Lyman. This is an excellent book, and I know it feels a bit of a cop-out giving the same rating again. I think this is an 8 out of 10. It's really good. There's been lots of 8 out of 10s recently. But
it's almost like you're choosing good books.
Well, I didn't know it was going to be a good book. It was recommended by a friend, but it's a really excellent piece of work explaining about how we've maybe been miseducated about what chronic pain is for a very long time, and helping gently introduce people without saying anything inflammatory like pain's all in your head, but it starts to introduce this idea of pain having a central nervous system component and helping people to understand what might be going on in their bodies a little bit more. And I thought it was really fantastically written. And I know that the author Monty has done quite a few talks that you can see sort of, he does events and things and has done some talks on YouTube. So we'll share a couple of them as well.
So I think that leads us to the end of this episode. I'd like to say from myself and both Joe and Don, thanks for listening. We'll see you next time.